Physical Therapy. Welcome back. Episode 4 in this first case study. And my family and I, we actually headed back to Michigan for vacation to spend time with my parents and enjoy the great outdoors of Michigan. And so I actually did some videotaping with my dad in regards to the layout of further progress of this case study. But as we got into doing it, sparked some brainstorming and some other things. So after doing it, I kind of backtracked and laid down a new blueprint in terms of the route and the direction which we'll go. So I'll involve my dad at a further point in time. But in episode 4 here, where I left off in episode 3 was a conversation I was having with my dad and him suggesting or asking, hey, what do you think is going on with me? And I left you hanging with, Dad, this is what I think you have going on. And so picking right up where we left off, and reassuring us all in terms of what we're going after and talking about, we need to make sure that the individual is within our scope of practice in terms of a clinician and treating. Otherwise, we need to be able to refer them out as quickly as we can in terms of maybe a suspected potential pathology that's underway or that's going on. We need to get them to the right help and the best help possible. That's why collaborating with others is good. But getting back to my dad, when he said, hey, what do you think I have going on? In my own mind, I was hypothesizing based on the questions that I was asking and what he was telling me. And I said, hey, Dad, what I'm going to tell you is probably going to scare you. But in my own mind, if someone came into my clinic and was presenting the same way you were and responding the same way you were with the questions or the responses that were given based on the questions I was facilitating, I would think that you had this, and I would say, prove to me that you don't have this. I wouldn't say that loud, but the inner chatter in my own mind. He said, okay, what's going on? I was like, well, it's going to scare you, but I think you have cancer. And he's like, what? Cancer? And my response was, you have these nocturnal pains at rest that are worse than at any point in time. These dependent positions in which you have these throbbing and excruciating night pains that wake you up. Your blood and your oxygen supply is feasted upon by cancer when we get in these positions and when we don't move. When you get up and start moving per your day, when you get that started, the law of supply and demand, you're going to have a blood supply and an oxygen supply that's needed at the tissue that's then being stimulated after you get up and moving. But at night, especially, red flag was no mechanism of injury, exacerbating factors in that, hey, I can't flare any of this stuff up. Although I can't reach up and put a cup of coffee in the microwave, maybe one hand in comparison to the other, depending on the day, and carry anything I want to waist high. I can't move anything away from me, weight-wise or body-wise, and lift and raise my arms. And I have no alleviating factors, and it's worse at night with these throbbing night pains, and it gets better when I start my day with movement. So movement and activity from an orthopedic standpoint, from a musculoskeletal standpoint, neuromuscular standpoint, is actually going to make things worse, not necessarily make them better unless there's some form of other degenerative thing going on. And so those are indications right there. And I said, hey, if I were to assess you, I'd go after you right away, and I would take a look at it, and I would want to know where's this stuff coming from? Prove to me again that you don't have this going on. And if I don't find via my best exam findings and through the assessment and through the evaluation reproducible signs and symptoms that are consistently making sense and clustering some good best exam findings to these pathologies, 100% I'm going to send you out and refer you out basically right away. I never look at really the prescriptions that I'm getting from physicians that I receive, because they're very frequently, vast majority of the time, very far from the truth, and something that's very general that covers a medical diagnosis, an ICD-10 code, which are used in terms of billable purposes. So I said in the conversation with my dad, I was like, Dad, hey, you need to, so you're in physical therapy right now, you're senior primary care physician, you need to start to suggest some things to them. I can't be that guy that's on the outside talking through you and saying, hey, my son needs to do this, this, and this. I can't be that guy, but what you need to start doing is kind of picking their brains and asking them these questions to kind of stimulate maybe some conversation by them, so that they can pick up on some things and get you the right help. You need to do that. And so here began this this process then of, later on down the road, and after the fact, I looked through these physical therapy notes and stuff like that, and look at all these medical documentations and notes, and there was little pieces of the puzzle that were put in throughout these notes that eventually everybody missed the ball on and stuff like that. So I would want to go after the neck, the cervical spine, the thoracic spine first. Hey, is it coming from the cervical spine? Do I have this arthropathy, this degenerative disc disease, degenerative joint disease that's taking place and kind of building up with osteophyte formation and other fascial-like formation that is building up around the neuroforamen, the nerve roots that are coming out, and that's creating this maybe potential radicular pain, multi-level tingling, numbness, and weakness throughout the system. We need to have multiple levels for it to be radiculopathy. Is it a spondylitis? So again, those are all degenerative-like terms, but I need to know, hey, is it coming from the neck? Get the reflex hammer out. Is it hyporeflexive? That's indication of degenerative changes affecting the nerve root. Is it hyperreflexive? Well, that's some form of encroachment centrally, potentially to the spinal cord. We don't know what that is. Maybe it's some form of growth or tumor or whatnot. And then from there, if that's okay, so let's say whether that's positive or negative. Positive, well, we're getting to figure out in terms of our tissue-specific impairment. Okay, let's figure out where and why that's formed. Let's get to the root of the problem, cause and effect. If that weren't the case, okay, let's go distally. Let's go and let's look for, let's say, like nerve lesions and stuff like that. Distribution-wise, in terms of the tingling and numbness, it was more of the index and the ring finger on the right hand. Occasionally a little bit throughout the index thumb and the middle finger on the right side, and the same over on the left, but the right more consistently exacerbated or kind of flared up than the left side. Which gives us an indication, hey, there might be some some ulnar nerve distribution related things kind of going on. Maybe a little bit median nerve. Let's take a look at that stuff. Let's run our upper limb tissue tension examination. So nerve, just like any other tissue, gets tight. Let's take a look at and see if we develop and get some reproducible signs and symptoms of the tingling and numbness and some of that pins and needles related stuff. Let's take a look at, as kind of, as bootleg as it is, some basic MMTs. Let's see if we can reproduce some things, and then let's take a look at our grip strength, other upper extremity strength, etc. Myself personally, I'd go right after cervical spine kind of lunge matrix with some dowels. I would go after some thoracic spine mobility related stuff. I would get them on wall with thoracic spine matrix and go from there. We already know in terms of the hip and the lower extremity from previous evaluation, in terms of kind of the disastrous mess and everything like that was going on there at the time, that cleaned everything up. And since then, to date, so over the past year and a half, no symptoms related to the degenerative joint disease in the hips anymore. Set him up with a mobility, stability, lower body lunge matrix, some self-manual therapy techniques and tools. He's good to go. So in my own mind, I want to be able to reproduce that stuff. My dad, they need to be kind of taking a look at this stuff, especially the clinic that you're going to. They have a background, they have a history in this stuff. They need to be able to use movement to put things together in terms of dotting the I's and crossing the T's to find out if you are within their scope of practice. So over the span of the next 4 weeks, he was continued to be seen in physical therapy 2 to I think 3 times a week occasionally. And there was a lot of quote-unquote kind of confusion and perplexity in terms of, hey, what's exactly going on here? A lot of palpation and a lot of some soft tissue work and a lot of kind of palliative care related stuff, which tells me as a clinician, hey, we don't know what's going on, we don't know what we're doing. And we need to be able to piece this stuff together. Looking at the notes after the fact, there was no special test and very minimal at best exam findings to give any indication for anything. It's like, well, for a month, what are we doing treating someone if we have no blueprints in terms of the approach that we're going after? But second, and maybe first and foremost, more obvious, what the heck is going on? What is wrong with this individual, tissue-specific impairment-wise? And where is it coming from? If we can't answer that stuff, we shouldn't be treating this patient for 4 or 5 weeks. So I'm like, Dad, hey, are they going after you with like a little reflex hammer? Because now what had started was that with his primary care physician, he'd been referred out to a neurologist. Right away. Oh, the symptoms, you have carpal tunnel syndrome. Let's schedule your surgery. We're gonna carve both arms open, shave you down, release the flexor retinaculum, and then you're gonna be good to go. And I said to my dad before that, I was like, listen, with what you're presenting with, you do not have carpal tunnel syndrome. And after the fact too, 100% you don't. So EMG studies, etc. began. Went to have an EMG study. Right side completely normal. The left side, maybe the median nerve a little bit affected. The radial nerve on the right side a little more affected, which is actually the nerve distribution of the triceps and the extensor common tendon group in the back of the forearm. And that stuff a lot of times is negative anyways, but ultimately when the conclusive evidence is that bilateral carpal tunnel, and I'm scratching my head, well, wait a second, you're referred from your primary care physician for supposed carpal tunnel potentially when there wasn't really any testing or assessments that were done. You go directly to some orthopedic surgeon and a neurologist who then, without even touching you and only in brief conversation, say you have carpal tunnel. They refer you to a guy that's running your EMG work who, because all these other people are saying you have carpal tunnel, then in his notes based on conclusive evidence says bilateral carpal tunnel when the median nerve's not even involved. What in the world is going on? And so medically we need to know that in terms of physicians, they're going to be passing things down. When you're labeled with something, there's not people that have the courage that are going to risk willingly going against what other people have said to do their own work, grab their own conclusive evidence, say, hey, no, you know what? This is what I think you have going on, and this is why. We need positive testing. We need to be able to understand when it comes to our tissue-specific impairments, how and why we develop that stuff. So we also had an orthopedic surgeon that wanted to fuse his cervical spine down after this EMG study because there's arthropathy, there's spondylitis, there's degenerative joint disease, maybe some degenerative disc disease a little bit from C5, C6, and C7 in that range. And we don't know if we're really symptomatic of that and where stuff is actually really coming from. First, let's hunt that stuff down because our imaging and how someone presents can both be completely different. You could have all kinds of degenerative changes and not be symptomatic, and vice versa. Based on imaging, it could look clear and perfect, and physicians say, no, you're fine, it's in your head, you're good, but you have all these degenerative changes and all these other things that are presenting you with these ridiculous-like symptoms. So ultimately, in conversation with Dad, I was like, Dad, 100% do not let them fuse your neck down, your cervical spine. Do not let them cut your arms open for carpal tunnel syndrome. You need to fly out to San Diego. Let me take a look at you because you're not presenting how I think they're stating in which you are and what you have. Do not let them touch you. He said, hey, you know, just in being a farmer, there's too much stuff going on. I can't get on out this time of year. Was seen a little bit more by physical therapists. Physical therapist then refers him ultimately back to his primary care doctor after a month or 5 weeks. Hey, we're not making progress. I think it's positive for carpal tunnel syndrome. Not one freaking test was done with reference for best exam finding for carpal tunnel syndrome. One thing for the neck for cervical radiculopathy. When we're labeling someone with having something that they don't have and we're not running and are giving good evidence for what we think they have, we can't put that in a note. And so the ball was starting to be dropped here by several individuals that were now starting to say, hey, symptomatically, we've seen that in a textbook before, we see this a lot. You have this, you have carpal tunnel, oh, you have cervical radiculopathy, let's fuse your neck down. Dad, don't do it.